We can start now, sir.
Thank you, Zalakben. So, on behalf of all of us, we thank our AOGS team, office bearers, Jignesh Bhai Munjal sir, to conduct such a nice academic program so that everybody can be updated. So, today's first topic is on anemia in pregnancy. We have expert of panel, Dr. Kanupriya Singh, Dr. Sugandha Ben, and Dr. Pooja Ben. And for students, we have super expert students, Dr. Meet, Dr. Priya Ben, Dr. Swija, and Dr. Naimesh. I would like to introduce the experts. Dr. Kanupriya Madam, she is Senior Associate Professor working at GCS Medical College and having vast teaching experience of 14 years. She is expert in laparoscopic and advanced vaginal surgery. So we welcome you, Dr. Kanupriya Madam.
Thank you.
Thank you. Thank you for joining us and thank you for being with us. Dr. Pooja Singh, we welcome you, Madam. She is again Associate Professor at GCS Medical College and she is Head of Unit. She is Fellow in Minimal Access Surgery and Fellow in Assisted Reproductive Technology. We welcome you, Dr. Pooja Madam. Madam, are you there? Hello, Dr. Pooja Ben.
Am I audible now?
Yes, Pooja Madam.
Yes, thank you, sir.
So we welcome you. Thank you for being with us. And our third expert is Dr. Sugandha Ben. She is Assistant Professor at Civil Hospital and again having a vast teaching experience of 13 years. All of them are our UG and PG students examiners. So I welcome you, Dr. Sugandha Ben. I request the experts to start the first case and I hope the students are ready with the case presentation. Dr. Sugandha Ben, Pooja Ben, Kanupriya Madam. Hello.
Hello.
Yes, sir.
Yes, sir. Yes, sir.
So I request the expert Kanupriya Madam, if you can please invite the students or you can start the session, please. In front of you. Thank you.
Yes, students, you can start with your history.
Okay, ma'am.
Yeah. Hello.
Yes, ma'am.
Yes. Please tell your name and then start.
Okay.
Yeah.
Ma'am, I'm Dr. Meet Patel, third year obituary resident at Hospital.
I'm Dr. Nimish Nathwan, the third year resident doctor from SVP Hospital.
I'm Dr. Anemia, resident SVP Hospital. I'm
Okay. Start with your history, please.
Yes,
Meet, you and Nainesh are audible, but colleagues are not clearly audible because they are sitting behind you. Their voice is not very clear. Take care of it. Kindly adjust accordingly because they are not audible.
Okay, sir.
Yes. I'm presenting case of 30-year-old
Meet, you are not audible. I am sorry for the interruption, Meet, but you are not audible. There is some coverage problem, or you can use somebody's network. Kindly check. You are not clear audible.
Okay, sir.
Hello.
Yes, you are audible now.
Okay, sir. I'm presenting the case of a 30-year-old Chaudhary with 8 months and of
Meet, I am sorry. Meet, I am sorry. You are not. Your voice is getting break. I asked the experts. Can you clearly hear them? I am not able to.
No. They are not audible.
So
Yes.
meet everybody is facing problem in hearing your voice. There is some problem. There is some connection problem.
Okay.
Just 1 minute, sir.
No problem. Take your time. You can change the network and please act accordingly.
Sir, am I audible?
Try to speak one statement. I shall let you know.
Okay. I am presenting the case of anemia in pregnancy.
No meet. No meet. Not audible, Dikra.
Okay.
Hello.
Yes, sir. મીત કોઈનું એરટેલ નું નેટવર્ક હોય તો વાપરો ને, એરટેલ નું કદાચ ક્લેરિટી સારી હશે.
A 30-year-old. Am I audible?
Constant.
Yes.
Yes,
Yes.
yes, yes, yes. Continue.
Okay.
Maybe by and by
Okay,
it will
okay.
become audible. Yes, start.
Okay, ma'am.
Yes.
A 30-year-old third-grader patient with 8 months 4 day of anemia was coming from lower socioeconomic class. Was admitted on 9 September 2021 with complaint of easy fatigability since 2 months. Previously, the patient was able to do her household work, but for the past 2 months, she gets tired even with minimal work. On brisk walking, patient complains of fatigability and giddiness, which is on rest. She attended 3 antenatal visits and had taken 2 doses of oxide.
Have you joined from 2-3?
Regular.
Just a minute, beta. Have you joined from 2-3 setups? Because I think there is some interconnection. Your mobile, somebody's mobile is on. Use only one device for joining. All of you 4.
Ma'am, we have connected only one device.
Only one device. Okay.
Yeah, same laptop we are working with.
There's lot of echo there. So there's lot of echo effect is there. Okay.
Your voice is breaking. Your voice is breaking.
I think you should rejoin, as sir was rightly telling. You should rejoin with another network.
Okay.
Yes.
Okay.
નૈમિષ કોઈનું એરટેલ નું હોય તો લો દીકરા, આપણે ત્યાં આગળ એસપીપી માં એરટેલ નું સારું કનેક્શન છે, તમે જુઓ ને એરટેલ નું હોય.
Okay, sir.
Yes, sir.
Sir, rejoining after lifting.
Okay.
નૈમિષ
Yes,
Yes,
sir.
sir.
હવે વોઇસ તમારો ક્લિયર છે દીકરા?
Okay, sir. Okay, sir.
Sir, can you allow for screen sharing?
Host.
ઝલકબેન?
Yes, now they can share.
ઓકે મીત, પરમિશન
Yes, sir.
ગ્રાન્ટેડ.
Okay.
Okay.
Okay, ma'am.
Yeah. Doesn't matter. Start with your history again.
Okay.
Yeah.
30-year-old third grader with 8 months of 4-day amenorrhea was coming from lower socioeconomic family, was admitted on 9 September 2021 with complaint of infertility since 2 months. Previously, the patient was able to do work, but for the past 2 months, she gets tired even with minimal work. On brisk walking, patient complained of fatiguability and giddiness, which is ignored on patient. She attended 3 antenatal visits and had taken 2 doses of tetanus. She was not taking hematinic regularly. Her menstrual history, LNP was 5th January 2021 and EDD will be 12th October 2021. Past menstrual history, he was regular, comes every 28 to 30 days for 3 to 4 days, moderate and painless. Our obstetric history is previous to full-term ND. First was male child 5 years ago, delivered in government hospital, no history of blood transfusion. Second child was female child 1.5 years ago, and history of blood transfusion 1 pint PCV was given at that time. Past history, no significant past medical or surgical history. Family history, no significant. Her personal history was that she is pure vegetarian. Appetite was decreased. Bowel and bladder habit is normal. She has a history of pica. Yes. On general examination, I have examined the patient with informed verbal consent with adequate daylight and exposure. Patient is fairly built and malnourished, conscious, cooperative, and well-oriented to time, place, and person. Her height is 164 centimeter, weight is 51 kilogram, and BMI is 18.96 kilogram per meter square. Her vital signs are pulse is 102 per minute, regular rhythmic, good volume. Blood pressure is 106 by 74 mmHg. Respiratory rate is 16 per minute. Temperature is normal by palpatory method. Pallor present in lower palpebral conjunctiva. No history of icterus cyanosis, clubbing, edema, lymphadenopathy.
Systemic examination. Her respiratory system, both lungs, air entry was present. On cardiovascular system, S1 and S2 is heard and they are normal. Obstetric examination. On inspection, abdomen is uniformly distended, globular in shape, and umbilicus is everted. Stria gravitant and linea nigra was present. No scar over any scar was not present over abdomen. On palpation, Symposium fundal height was 28 centimeters, that is corresponding to approximately 32 weeks. On fundal grip, soft, broad, and non-palatable was felt, which is suggestive of breech part. On lateral grip, no black strictures on the right side, suggestive of limb buds. Uniform resistance on left side, suggestive of back. On first pelvic grip, smooth, hard, palatable mass, which was suggesting a head. And on second pelvic grip, finger converged, so head was not engaged. On uterus was relaxed. On auscultation, the fetal heart sound heard along the left spino-umbilical line, which was 144 by minute and was regular. So my probable diagnosis is the 30-year-old female with she is third gravida with 2 full-term ND at 32 weeks pregnancy with anemia with single fetus vertex presentation on LOA position, non-engaged head, and with fetal heart sound present at left spino-umbilical line with 144 per minute and regular.
Thank you, ma'am.
Thank you.
You told that on examination edema was absent. Was it there?
No, edema was not there.
So in this patient would fall in the category of which mild anemia or severe anemia according to your examination?
Ma'am, we have done some investigations in that CBC.
From your examination part,
Okay.
She's
which pallor was there?
yes, moderate.
Moderate anemia.
Can you give us the definition of anemia?
Okay.
Can
It
you
is-
define anemia?
It is the low hemoglobin level, which later reduces the decreasing oxygen carrying capacity to the tissue. So if we categorize according to the level of the hemoglobin, then according to the WHO, the level of HB less than 11 gram is defined as anemia.
Okay, so what is the difference between the WHO guideline and the CDC guideline?
According to the WHO guideline, anytime in the pregnancy, if the HB level less than 11 gram, it is anemia. But according to the CDC, it is less than 11 is considered only in first and the second trimester, while in the second trimester, first and third trimester, while in the case of second, 10.5.
So only antenatal WHO has defined, or something else is also there in the definition? What about the postpartum? 11 is for the antenatal and postpartum is less, 10.5 gram, right?
Yes.
And CDC is for each trimester, it is giving 11 for the first, for the mid trimester it is 10.5, and again it is 11. Okay.
Okay.
So
Yes, ma'am.
right. So madam was asking, it is mild. Which type of anemia it is?
Moderate, ma'am.
So which is this? This is the degree of anemia classification. Which other classifications are there for anemia? Any other classification?
ICMR classification.
Yes. What is it?
It says that less than 5 gram is severe. It is severe anemia, and in mild.
Yeah, degree of anemia: mild, moderate, severe, and very severe.
Very
right?
severe.
That is there. ICMR WHO classification, which is there. Any other way you can classify anemia? There are numerous classifications, no? Depending upon the etiology.
Yes, yes.
તમારે પણ જોતો છો ને તમારો મારે ચાલવા નીકળો મારે
You are not audible.
Yes, ma'am. Am I audible?
Hello.
Yes.
Yes. Actually, and from our side, the network is okay.
Yes, sir, from your side, network is. Acha, what are the positive points that you elicited in your history that made you reach this diagnosis?
Okay. Ma'am, on general examination,
Starting from history, you should not just jump into examination. You should start simultaneously as you have taken the history. It should come point by point.
First, the patient was belonging.
Seen here. You're connected.
People are also not audible.
Hello.
Hello. Yes.
Yes.
બરાબર છે.
મીત કોઈ કારણથી એવું થાય છે કે નૈમિષનો અવાજ સંભળાય છે, તારો નથી સંભળાતો. જરા
yes,
એંગલ
yes,
ચેન્જ
sir.
કરી શકો?
Okay. Yes, sir. Am I audible?
Yes, yes.
In history part, patient is coming from lower socioeconomic class family. Then second point is she is multi-para. Then her second child was 1.5 years ago. Then ma'am, she is malnourished according to height, weight, and BMI. Then ma'am, she is dietary pure vegetarian from diet, and history of pica was present. And then
In the last delivery, she had the
history of
the blood transfusion.
Yes, yes, very good.
And on general examination, was
Again, your voice is breaking.
On examination, the pallor was present over lower palpebral conjunctiva.
Yes.
ma'am, and complaint of easy fatigability and giddiness since 2 months.
Okay. So she is admitted. She has been admitted for 2 months. You said.
No, ma'am. She is not visiting regularly. She has taken only 3 antenatal visits, and now we had CBC of her CBC of her, and HB is 8.4 gram percentage, and complaint of fatigability and giddiness. So now we had admitted the patient.
Can you not diagnose it as physiological anemia of pregnancy? What is the difference? What do you mean by physiological anemia of pregnancy?
Ma'am, in physiological changes, RBC, blood volume.
First, ma'am, her HB is 8.4. So before defining the physiological anemia, it should not be less than 10.5.
Yes.
Yes.
It should decrease by only 2 gram percentage. It is more than 2 gram percentage.
Why does this happen?
Hemodialysis.
Might be her pre-pregnancy hemoglobin was not good, and further.
I'm talking about 8.5 hemoglobin. I'm talking about why does physiological anemia in pregnancy happen?
Due to increase in plasma volume.
Anemia in pregnancy, there is an increase in plasma volume, and as compared to plasma volume is increased as compared to red blood cell mass. So there is a hemodilution of HB. HB is decreasing by 2 gram per deciliter. So there is a hemodilution in anemia in a pregnancy, physiological anemia, ma'am.
Okay. Why there is physiological anemia in pregnancy? Is it good or bad for the pregnancy?
It is good for pregnancy.
Why?
There is a increase blood flow to the placenta or decrease viscosity in the blood. It will decrease the load to the heart, and also increase oxygen carrying capacity to the blood, or it also prevent more blood loss after delivery or
Okay.
PH.
Okay, so blood becomes less viscous. So it is preparing itself for the blood loss, which is going to occur at the time of delivery.
Yes.
Okay, in this patient, some other tests or investigations you would like to undergo?
Yes, ma'am.
Which are those?
We'll first of all, as we define that complete blood count, then we'll go for peripheral smear.
So how would be the peripheral smear picture?
Is microcytic hypochromic picture will be there.
So that is what it
Iron
is. It means iron deficiency.
Iron
anemia.
deficiency anemia.
Any other thing in the peripheral smear? No. In iron deficiency, what is the peripheral smear picture?
If the it's anisocytosis.
What is that? What is anisocytosis?
Abnormal in shape and size. Anisocytosis and poikilocytosis.
So poikilo is abnormality in the shape or size? Shape. Poikilo is
Shape.
And aniso is size.
Size.
Right?
Yes, ma'am.
Okay. Some target cells may also be seen.
Yes.
Right.
Or there is a central pallor in RBC.
So how this picture?
Okay, go on.
Yes, you ask. Wait, no problem.
Only your CBC and peripheral smear can tell you a lot of things.
Yes, ma'am.
So in CBC, what all are important? In peripheral smear, you will get a picture which are going to guide you towards the type of anemia you're going to deal with.
We have.
Yes. Go on.
We have also seen MCV, MCHC indices, blood indices. In that, MCHC is a more sensitive indicator of iron deficiency anemia. It is lesser than normal value.
And also it will helpful to differentiate between whether it is thalassemia or the iron deficiency anemia. And further, we had investigated for the iron deficiency anemia.
So what will be there in thalassemia? What will happen to the mean corpuscular hemoglobin concentration? MCHC you are telling. No. What will happen to that in thalassemia?
It remains normal.
What other investigation differ in thalassemia and iron deficiency anemia?
Ma'am, Menzer's index is there, ma'am.
Which?
Menzer's index. Which in the case of iron deficiency anemia, it is less than 13, while in case of thalassemia, it is more than 13.
Anything else? Any simpler things?
Yes, ma'am, serum ferritin, total iron binding capacity that remains normal in the case of thalassemia.
Because iron stores are normal in thalassemia, while in iron deficiency anemia, iron stores are depleted. Serum ferritin is normal in thalassemia.
Even in the case of thalassemia, the hemoglobin electrophoresis says that the fetal hemoglobin is more, that is more than 2 to 3%.
HbA2 increases by 3%.
Okay, so this is a patient, she's 32 weeker. And she has come to you with the 8.5 hemoglobin. So how would you like to, further go and manage this patient? What will be your modality of management?
First of all, we will try to counsel the patient to admit. Hello.
Hello.
Yes, ma'am. Am I audible?
Yes, you are audible.
First of all, we would like to counsel the patient and her relative to admit in the ward. And
why do you want to admit this patient?
Ma'am, because she had a complaint of fatigability and giddiness since 2 months, and patient had not taken regular visits. So we would like to. Sorry, ma'am.
What can be your differential diagnosis?
It may be ma'am iron deficiency anemia. It can be a malabsorption syndrome or
anything else.
Any cardiac related conditions. We'll go for ECG and echo 2D echoes.
So tell me further about management after admission.
After admission, we would like to go for all investigations and injectable iron therapy. We would prefer to give patient.
Okay, so you want to give parenteral iron, right?
Yes.
So what is the indication for giving a parenteral iron therapy?
Yes,
per se?
Okay, ma'am, non-compliant to oral therapy, intolerance to oral therapy, and moderate to severe anemia in 3rd trimester in pregnancy.
So in moderate to severe anemia, you will give parenteral iron after 36 weeks.
Mild to moderate anemia. In severe anemia, we would like to give blood transfusion.
Yes. So which are the parenteral iron which are preferred?
Ferric carboxymalate.
Iron sucrose and ferric carboxymalate.
So you like to give
these two compounds?
Sorry,
what is the difference between iron sucrose and ferric carboxymalate?
Iron sucrose is a second generation inject parenteral iron.
What do you mean
What
by
is
second generation?
the advantage?
Sorry, ma'am.
What do you mean by second generation iron?
How the generations are defined in the parenteral iron?
Size of molecular weight of the
According to
molecular weight of the iron. Iron dextran is a first generation, iron sucrose is second generation, and carboxymaltose is a third generation.
So what is the advantage of iron sucrose over iron dextran?
Iron dextran is hyperabsorption is late in iron dextran. There is a time 3 to 4 week for absorption, and there is a
3 to 4 week is very long time for absorption. Till that time, so she will become full term. 3 to 4 weeks.
Hypersensitivity reaction.
Bioavailability is after 3 to 4 days of iron dextran as compared to iron sucrose, which becomes bioavailable in 6 hours.
And also
right? That is the main difference. Otherwise, the compound is inferior. Iron sucrose is not that stable as compared to dextran, but it is very easily bioavailable. Okay.
Yes.
Right. Any other difference? Advantage of iron sucrose?
Iron dextran give IM and iron sucrose give IM.
Yes.
So less
Local side effects, staining. There will be
and most important,
hypersensitivity.
Yes, and it requires a test dose,
Test dose.
whereas iron sucrose does not
Not
require.
required
So
test
how will
dose.
you give iron sucrose? How do you usually give? Administer?
8 milligram in 100 ml NS, normal saline over 30 minutes slowly. Alternate day, week ma 3. Maximum 600 mg.
Okay.
Ma'am,
The dose schedule may vary.
initially
Yes.
20 to 30 drops in 15 minutes and after 80 to 90 drops per minute in rest 15 minutes.
Okay. Somebody said about FCM.
Yes, ma'am.
Yes. What is it?
It is a very
Carboxymaltose with which can be given in one sitting 1000 milligram we can begin over the 15 minutes, and it can begin 15 mg per kg. It is an IV preparation.
Okay.
Is there any advantage of giving parenteral therapy over oral therapy if the patient is taking oral therapy regularly?
Yes, the first thing is
If oral is being taken properly, or if you go for parenteral island, they both give the same result.
yes,
It's
the result is the same.
how many weeks we are having, and plus we need to be sure that iron is going to the patient's body.
Yes.
For that purpose only, we are switching over to the parenteral iron. So what will be the first thing that you will notice after the therapy has been initiated? Look, if this patient is now giving response.
First is the patient will have the good feelings. If she is having,
sense is going to improve.
then we go for reticulocyte count. First thing is to increase the reticulocyte count.
And how much hemoglobin is going to improve in the body?
On an average, ma'am, 1 gram or 0.7, 0.5
per week.
per week.
It is per week.
And generally, it is our target. If we watch for 3 weeks to get the response.
What if? Okay, fine. Why are we so worried about anemia in pregnancy?
Because, ma'am, it has the bad effects on the antenatal period to the mother as well as the baby.
What about the burden on the health infrastructure as a whole in a developing country like India?
It is more than 40% prevalence is there.
Yes, and plus
Anyone 50%.
50%,
maybe around 58 to 60% that you can see, check your
incidence is about 80%.
maternal mortality and morbidity.
Yes.
So how much does it contribute to maternal mortality?
50%.
50%. And what about other things? So whole of 50% is anemia. Huh?
Incidence is 80%.
Incidence prevalence is 20 to 80%, and it is contributing to MMR 20%, 19 to 20%. Right? Other factors are also important. Right? Hemorrhage is the biggest factor. It's around 30-35%. Okay.
How is anemia going to affect the pregnancy?
First, ma'am, in the antenatal period, there will be preterm pregnancy-induced hypertension will be there. There will be poor weight.
Pregnancy-induced hypertension occurs in cases of anemia in pregnancy.
What is the reason of preeclampsia?
Because of the less oxygen.
Go on with your antenatal complications, list of complications.
Okay, there will be chances of the abruption, infections, and in the during internatal period there will be high chances of the postpartum hemorrhage, uterine inertia, subinvolution, purpular sepsis, chronic infections, delayed.
So which are the most dangerous period in an anemic patient in whole of her antenatal and postpartum
during
period?
the third stage of the labor and immediate postpartum.
Why in the third stage of labor?
Suddenly increases.
What can happen in third stage of labor?
Auto transfusion lead to
increase in sudden increase in cardiac output, which is
Yes,
increase
there will be
workload
more
of heart.
blood going back into the system because of the hyperdynamic circulation, right? So there will be cardiac overload, and there are more chances of CCF at that time.
Yes.
Any other point which is more dangerous? Any other period?
Immediate postpartum period.
Third trimester.
Immediately postpartum, yes. At the time of labor, immediately postpartum, and during antenatal.
Third trimester.
32.
Not the third
Gestational age, to
trimester.
be
It is
precise.
actually, yes, 28 to 32 weeks,
Yes.
because that is the time of maximum hemodilution. So
Okay.
cardiac output is very much enhanced. So that is the time when CCF can occur.
Okay.
What about fetal complications then?
Intrauterine growth restriction may occur. Sometimes even low birth weight, IOD baby, perinatal mortality,
Fetal anemia.
fetal anemia, cognitive and behavioral
impairment.
even the long-term effects the child will have, in future they will have the diabetes or the hypertension.
Okay.
From
So
history,
some, yes.
what else you would like to give her in a treatment?
Yes, we will give prophylactic deworming like albendazole single dose 400 mg or mebendazole 100 mg for 3 days. In case of the or we'll go for investigate for any malaria in endemic regions.
What are the other types of anemia? You are not audible.
Voice is gone.
Not audible.
ભાઈ તું નૈમેશની જગ્યાએ જતો રે દીકરા કઈ બોલવું હોય તો.
According to etiology, there are two types of anemia: hereditary and acquired. In acquired, nutritional, acute hemorrhagic anemia, acute anemia of chronic disease, and inherited sickle cell anemia, thalassemia, and congenital hemolytic anemia.
So tell me something about sickle cell anemia. What happens?
Ma'am,
Valine replaced glutamic acid in sixth position, lead to changing the shape of the RBC.
Where? In what?
Sixth globin chain.
hemoglobin.
Chain sixth position for.
Yes.
So
So it will lead to abnormality in morphology of RBC, after any stress or hypoxia or infection will lead to sickling and decrease oxygen carrying capacity. And later on, it will lead to vaso-occlusive diseases in liver, lungs, and eye. We have to check for it.
So what is actually happening because of anoxia?
For oxygenations, the tissue of
So the hemoglobin is precipitating,
yes,
right? And it is forming a crystal,
yes,
right? So then they're occluding the small arterioles, right? So it causes microinfarcts,
yes.
right?
what is the
So
role
what
of-
type of defect it is? What type of defect will you call it?
It is qualitative.
It is a qualitative defect, and whereas in thalassemia it is a
Quantitative.
It is in the number of chains which is formed. So it's quantitative.
what is the role of preconceptional counseling in hemoglobinopathies?
In thalassemia and sickle cell anemia, we would like to go for screening for both partners for HBS and thalassemia screening, and then if in antenatal period we would like to counsel for amniocentesis or chorionic villus sampling.
Will you explain to
So-
parents?
Oh, sorry.
So what if the mother is having beta thalassemia trait,
Yes.
right? So what do you do now?
First of all,
You have
we
diagnosed,
screen-
you've done electrophoresis, even PHCs are doing. So what do you
Yes.
do now?
first of all thing, we have to check our partner status for thalassemia. If both are the
Yes.
minor, then we will advise not to conceive.
No, she has already conceived. That's
Okay,
why we
conceived.
got the electrophoresis. She came to
Okay.
us because of that. Now
Then
what you do?
chorionic villus sampling,
So-
we will go.
Yes. So you will explain to her what is the chances of her. Yes.
If the baby is thalassemia minor or thalassemia major, if diagnosed as thalassemia major, we would like to advise for
For
termination.
Yes. And even if she is not affording, you can just.
Partners are trait.
Sorry, ma'am.
What are the chances of having
Yes.
1:2.
No, 25%.
Yes.
25% chances of thalassemia major in
So
both.
it is very less. You cannot say
Yes,
somebody not to conceive.
Yes. You
But
can't
to
ask.
go for, we should go for that the CVS or the amniocentesis.
Yes, 25% chances of having.
Yes.
Okay. So now this patient of yours, how would you manage if in labor she comes to you, she is full term, suppose, how would you manage such patient?
First of all, ma'am, in the first stage of the labor, we'll give the proper positions with the proper oxygenations, and we'll give the proper labor analgesia. The fluids will not be overloaded. It should be restricted at 75 ml per hour, and we will encourage to take the oral fluids. While in the case of the second stage of the labor, we will use the cut short the second stage by using the forceps. And in the third stage of the labor, we will active management of third stage of the labor is to be done by giving the oxytocin.
Which ecbolics will you like to give? Oxytocin only, or you will with that, because oxytocin is bolus and it has to be
Yes.
given with IV fluid.
Yes.
So which are the preferred ones?
We'll go for, ma'am, if her blood pressure will be normal, then we'll go for the methergine.
Okay, and what about misoprostol per rectally? Can't we do
Yes,
that?
we can go for the same.
No, we can give an intramuscular syntocinon, and then we can give a misoprostol instead of giving an IV bolus of oxytocin infusion, right?
Even the oxytocin should be given concentrated form, or either IM we can give.
What about the puerperal period, postpartum period?
In postpartum period, we have to give her antibiotic for 5 days to prevent infection and
Proper
prop-
iron and hygiene,
hygiene.
proper hygiene, diet explanation.
and iron tablets to be started in postpartum period.
What is Government of India guidelines? What is National Iron Plus Initiative? What does it say?
Ma'am, in that 6 beneficiaries are there. In 6 beneficiaries, they divided in age groups: 6 months to 5 years, 5 years to 9 years, 10 to 19 years, women of reproductive age, pregnant woman, and lactating woman. In that, we have given 6 benefits to the this age groups. In that, digital hemoglobinometer, delayed cord clamping, fortified food, deworming,
Iron
folic acid,
supplementation.
and 6
The prevention part.
Sorry.
This was for the preventive. This is the preventive aspect. Right?
Yes,
You're
yes,
telling me.
yes.
Okay. And what is then postnatal anemia?
Postnatal anemia is maybe due to acute blood loss after delivery. Is maybe
Yes.
due to acute blood due to PPH.
Okay, fine. Then you're going to put her on hematamic.
No, ma'am. According to the degree of severity of anemia, ma'am.
What is the role of then this blood transfusion then? in the case of anemia in pregnancy?
But if HB is less than 5 gram percentage is in any trimester, or HB is less than 7 gram percentage in third trimester, or acute hemorrhagic blood loss,
or any patient is hemodynamically unstable,
beta cell measure,
we can give
blood.
Parity and requirement.
Sorry. Hello. Ma'am, your voice is not.
Can I say something?
Yes, sir.
No, I'm asking the respected madams.
Okay. Sorry.
Yes.
Yes, sir.
Madam, last 1 minute and time.
Yes, sir. We are finished.
So,
thank you, ma'am.
Kanupriya madam.
You would like to
Thank
ask
you.
us
Good.
for
Good show.
positive advice.
So, thank you so much, respected madam and dear friends. It was a very nice conversation. So, thank you. I would like to say now invite Dr. Kirtan to conduct second session on the second with the help of second team of experts and our students. Dr.
Thank you, sir.
Thank you, dear friends. Dr. Kirtan. Hello, Kirtan. Give me 30-second time and Dr. Kirtan shall start the second session.
Unmute we are not able. So
and thank you so much for students to the first session and also the respected faculties. Now we move towards our second session.
we are not.
Invite our faculty for the second
Kirtan sir, your voice is not very clear.
ચલો આપણું ક્યાં છે
દીકરા તમારું અહીંયા જ છે તમે હમણાં અનમ્યુટ રાખો.
Hello, now better sir, my voice is better sir.
Kirtan ના Kirtan, હજી voice ની clarity is not up to the mark.
Hello.
Kirtan better
sir. Yes sir. Okay, so
please
the
go
second
ahead.
session, second session is a case of primary infertility, and case is to be presented by students of AMC Met Medical College and LG Hospital, Dr. Anmol Agrawal, Dr. Nikita Pahwa, and Dr. Hello.
Yes sir, you are audible.
Yes sir, and I would like to invite our expert faculties, and the faculties for the second session of case of infertility are Dr. Sumesh Chaudhary sir. First of all, we would invite Dr. Sumesh Chaudhary sir. He is a classified specialist of obstetrics and gynecology from Army Medical Corps. He is presently the associate professor in Institute of Kidney Disease and Research Center. He has in special interest in urogynecology, IVF, and endoscopy. And
Kirtan મોટેથી દીકરા.
Yes sir, also in high risk obstetric pregnancy, in post renal transplant and chronic renal diseases patients, and he has to his credit more than 35 publications. So we would welcome Dr. Sumesh Chaudhary sir.
Hello. Hi Kirtan.
Yes sir.
I am here.
Yes sir, good to have you with us sir.
I am audible now?
Yes sir, of course.
Okay. Hi Akshay, how are you?
All good sir, grace of God and blessings of people like you. I am doing fine. Thank you sir.
Yes sir. Our other faculty for the case is Dr. Pallavi Ninama madam. Dr. Pallavi Ninama madam is presently the associate professor in Department of Obs and Gynecology. She has to her credit many research publications and as well as training experiences. She has the list of publication is too long. Cesarean scar pregnancy, a case of conservatively managed clinical rarity in 2018, a case of postpartum acute kidney injury and falling trend in developing world in 2016, Cardiac diseases with pregnancy, a study of maternal and fetal outcome in 2015, an uncommon case of prolapsed pedunculated submucous fibroid in 2014, the prognosis of fulminant hepatic failure in pregnant women due to hepatitis E in 2013, and serum uric acid as a prognostic marker of pregnancy induced hypertension in 2012. So it is good to have you, Dr. Pallavi Ninama madam, with us for the case of infertility. We welcome you, madam. Our another faculty is Dr. Jayun Joshi. He is an associate professor in AMC Met Medical College in LG Hospital. We welcome you, sir. Is Jayun sir there? Hello.
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 Yes, sir. Jayun sir.
Kirtan, કેમ છે મજામાં?
Yes, sir. Yes, sir. Good to see you, sir. Good to see you.
કેમ છે મજામાં?
Yes, sir. Yes, sir. So I think we can
બોલ.
ask our students to go ahead with the case presentation.
Yes.
A case of primary infertility.
Yes, he.
Presented by students of AMC Met Medical College.
Good evening, sir.
Good evening.
Good evening, Baka.
Yes, yes.
Uh,
Please go ahead. Please go ahead.
Yes, my name is Dr. Nikita Pahwa.
My name is Dr. Anmol Agrawal.
And myself, Dr. Hayati Lakhani, sir. We are going to present the case of primary infertility today.
My patient named Mrs. XYZ, 22-year-old Hindu patient, Nali Gravida from Maninagar, belonging to middle socioeconomic class, having active married life of 3 years, housewife by occupation, presented to the LG hospital with complaints of facial hair growth since last 4 to 5 years, irregular menses since last 1 year, weight gain since last 1 year. Her menstrual history, she attained menarche at 12 years of age. It's her third day of this cycle today. Her last menstrual period was 4th August. Present menstrual history, she had cycles of 45 to 50 days with 3 to 4 days of flow, and she changes 2 to 3 pads per day. There is no history of dysmenorrhea. Marital history, she is married to Mr. ABC, aged 25 years since last 3 years. It's a non-consanguineous marriage and he is a clerk by profession. He has no history of tobacco, alcohol or any drug abuse. They are sexually active and they are having regular unprotected sexual intercourse with frequency of 2 to 3 days per week. She is not giving any history of dyspareunia. Past history, she had undergone ultrasonography, which was suggestive of bulky ovaries and normal uterus. She had undergone a hysterosalpingography, which showed bilateral free spillage of dye. She has taken 2 to 3 cycles of ovulation induction outside in private hospital. Medical history. She had no history of diabetes mellitus, hypertension, hypothyroidism or hyperthyroidism, tuberculosis or any other medical condition. She had no history of any pelvic or abdominal surgery. She had no history of vaginal discharge, no history of any allergy to any medication, and no history of use of tobacco, alcohol, or any other drug abuse. There is no significant family history. Her personal history included a mixed diet with normal sleep and bowel and bladder habits.
General physical examination. We have examined the patient in proper daylight with proper exposure and maintaining her privacy. Patient is conscious, cooperative, and well oriented to time, place, and person. She is obese. Her height is 160 centimeters. Weight is 65 kg, according to which her BMI comes out to be 25.39 kg per meter square. She has facial acne and hair growth over upper lips and chin. There is no pallor, icterus, cyanosis, clubbing, or any lymphadenopathy. Her breast examination is normal. Patient was vitally stable. Her respiratory, cardiovascular, and nervous system were normal. On per abdomen examination, on inspection, umbilicus was inverted. There was no other abnormality. There was no abnormality over the skin. On palpation, per abdomen palpation, per abdomen was soft and there was obesity was present, and there were no any scar present over the abdomen. On per speculum examination, cervix was healthy, pinpoint and centrally located. For vaginal examination, uterus was anteverted, normal size, bilateral fornices were clear, and there was no white discharge.
On investigating the patient, her CBC electrolytes were normal. Her fasting blood sugar was 120 milligram per deciliter. Her serum TSH and prolactin levels were normal. Her serum FSH was 6 milli international unit per ml. Her LH level was 18 milli international unit per ml. Serum AMH was 7 nanograms per ml, and her Montux was negative. Her husband's semen analysis was normal. On radiological examination, ultrasound suggested uterus which was anteverted and normal size. Bilateral ovaries showed 4 to 5 mm multiple follicles and ovarian volume of 15 cc. Endometrial thickness was 4 mm and her USG abdopelvis KUB was normal. From the above case, we can say that our probable diagnosis is 22-year-old nulli gravida whose AML was 3 years and had primary infertility, which was probably secondary to polycystic ovarian syndrome. Thank you.
So basically, what is the diagnosis? You are saying PCOD. So,
yes, sir.
So how will you proceed this case?
So patient is a case of, she wants to conceive. So first, our foremost task is to make her conceive.
Sir, it's a case of primary infertility secondary to polycystic ovarian syndrome, sir.
Okay, PCOD is one of the diagnosis, clinical diagnosis and biochemical diagnosis you have made.
Yes, sir.
So now we have to go through since 22 years with PCOD.
Yes, sir.
Yes, sir.
So in PCOD, patient with LH is very high.
Yes, sir.
Yes, sir.
In this case. So this is basically ovulatory factor for infertility.
Yes, sir.
Yes, sir.
So this case, leave this case.
Yes,
yes, sir.
Now, what are the other factors for infertility?
So tubal factors, uterine factors, cervical factors, then male infertility and unexplained infertility.
So you have not done the semen analysis of the husband.
So we have done. It is normal.
It is normal.
We have mentioned it is normal, sir.
What is normal semen analysis?
Normal semen analysis has a criteria of WHO according to 2010, which should be the quantity of semen should be 1.5 ml, almost equal to 1.5 ml. pH should be more than 7.2. Then the counts should be 40% should be total 40% count should be progressive. The
first count. You have missed the count. 15 million. Okay.
More than or equal to
40% motility, 32% progressively motile.
Morphologically, 4% should more than 4% should be normal morphological forms.
Yes.
And the fructose and the WBC count should be less than 1 million per ml, and the round cells should be less than 5 million per ml, and the viscosity should be less than 3.
Nikita, do you want to repeat the count after a month or not?
Yes, sir. Because first, before saying any abnormality, 2 semen analysis should be done at an interval of 4 weeks.
Good. Very good. Okay, fine. Sir, please.
Now you have found out that she doesn't have any uterine factor, she doesn't have a tubal factor. But how we do manage this case now? PCOD. It is polycystic ovarian disease or polycystic ovarian syndrome. You have got all the biochemical parameters with you. This 22 years old.
Sir, first we will relieve her. First, we will go for symptomatic management. First thing is she's obese with high BMI. So first we will go for lifestyle modification, that is weight gain, because even minor weight gain will resume her weight loss will resume her ovulatory cycles. So ovulation, sir, weight loss.
Fat. Sir, actually, in an obese patient, fat acts as a mediator for conversion to testosterone androgen level increases. So brisk walking would decrease the peripheral fat level,
androgen
and the conversion would be less. So in that case, we'll manage patients symptomatically according to her symptoms. Sir.
And even hirsutism will be less, because if androgen excess is cured, then it will decrease.
Okay.
Androgen, where androgen comes from basically?
Sir, androgens are secreted from the theca cells or because of LH. LH stimulates theca cells to secrete androgens.
And other part of androgen comes from where?
Adrenal
Adrenal
glands.
glands.
Sir. Adrenal
How
glands.
will you differentiate that it is from adrenal gland or it is from ovary?
So we have done USG over here, which rules out any adrenal pathology. Apart from that, the other
USG.
probable DD could be late congenital adrenal hyperplasia, which is one of
Yes.
the DDs of polycystic ovarian syndrome, sir. For that, we need to do 17-hydroxyprogesterone test, which will rule out CAD from
Differentiate
this.
between PCOS and congenital adrenal hyperplasia.
Yes, yes. And other test, DHES, dihydroepiandrosterone sulfate.
Yes.
That
Yes.
if it is more, it is from adrenal.
Adrenal gland. So at least you have ruled out with these two tests that you have not done.
Yes.
So
Yes, sir.
you have to do it to rule out whether it is a ovarian pathology or it is a adrenal pathology. Okay. Now there are other symptoms, other features you have found. She is obese because of androgen, high androgen. She has got hirsutism. She has got infertility, and she has got irregular cycle. But in irregular cycle, you have written 45-day cycle with 3 days of bleeding and this. So it is matching with the basically this clinical profile.
So it is oligo-ovulation. We have mentioned like PCOD can be anovulatory or oligo-ovulatory, sir. This cycle is suggestive of oligo-ovulation, sir.
Oligo-ovulation, what happens in oligo-ovulation? What do you basically
So there are
understand?
every year 8 menstrual cycles. That is oligoanovulation.
No, you tell me what happens in the menstrual cycle basically. What ovary does, what is the ovarian, what is the function of the ovary, how endometrium grows, then how it
Sir,
happens.
actually, because of continuous estrogen stimulation, there is a high LH and progesterone is deficient, and therefore there is anovulation.
Anovulation. So what endometrium will be thin or thick?
So it would
So
be
thick endometrium because of hyperestrogen.
unopposed action of estrogen.
So what she will have when she is not ovulating. So there is deficient of progesterone.
Yes, sir.
Yes.
So only proliferative endometrium is there.
Yes, sir.
Yes, sir.
Till estrogen supports, then only till the endometrium is there. If estrogen support goes off, then there is shedding of the endometrium.
Yes, sir.
So she will continue have a bleeding for how many days?
So more bleeding. Estrogen breakthrough bleeding is more.
So, but in history, you have told only for 3 days she is having bleeding.
Sorry.
Yes.
Understood?
Yes, sir.
Yes, sir.
Yes. So now that part. Now we come to the investigated. We have found that this testosterone is mostly from the ovarian side. It is not from the adrenal side.
Adrenal side.
For hirsutism, what you will treat her? Everybody wants to be beautiful. You told her to reduce the weight. Okay, it is very difficult. Only you can tell the patient to reduce the weight, but 90%, 75% of patient, only 25% can be able to reduce, or 75 will not be able.
Yes.
Okay. So drug therapy will talk later on. All these things. Second is hirsutism. How will you treat her hirsutism?
Sir, hirsutism, we have to give anti-androgenic drugs like ciproterone acetate, drospirenone or spironolactone, finasteride, flutamide.
Finasteride, glutamide, all these things.
Yes, anti-androgenic.
And what all they causes?
So it would inhibit the action of 5-alpha reductase. So in that case, testosterone production to active form would be less.
That is. Yes. And what will happen to the libido? She will have mood depression and everything with 5-alpha.
Yes.
Okay.
Yes.
And you want that she should conceive also.
Conceive. Yes, sir.
And you are giving all the drugs which will cause infertility, but basically make her infertile. These are all OC pills, oral contraceptive pills, part of oral contraceptive pills, cyproterone acetate and other things.
Sir, your voice is break.
Hello.
Hello.
Now you are able to listen to me.
Hello.
Sir.
Yes, sir. Yes,
Yes, sir. Yes, sir.
So tell me the
Sir, in
definitely
that
how.
case, hyperinsulinemia is,
Tell hyperinsulinemia. I want to
sir,
listen.
hyperinsulinemia is also one of the factors for which would contribute to increase in androgen level. So in that case, we can go for metformin, which would reduce the insulin and which can be helpful for that.
And it will also, sir, hepatic sex hormone binding globulin can also, if we give metformin, then that production will also increase because liver will start functioning properly. So sex hormone binding globulin will increase, which will decrease the free testosterone levels, and through which we can also help decrease hirsutism. Sir.
Hirsutism. So metformin, have you seen metformin decreases the hirsutism? Anywhere you have heard or read? Why metformin is given?
Sir, for insulin to overcome insulin resistance.
So what metformin does basically?
It decreases hepatic gluconeogenesis.
And it increases the peripheral utilization of glucose. So peripherally, glucose would be utilized more.
And it is an insulin receptor sensitizer.
Sensitizer, yes, sir.
Yes. So we are here, we are just treating her hirsutism. So hirsutism, you can give her what? Spironolactone?
Yes, sir.
Spironolactone.
Yes. Cyproterone acetate comes with
ethinyl estradiol. Sir, it comes in
ethinyl
OC pills.
with dine 35 it comes, no?
Yes,
ethinyl
yes.
estradiol plus cyproterone acetate.
30 milligrams.
If she would not have tried to conceive, then you would have given her OC pills
Go
also.
for OC pills, yes,
sir.
That
But
is
she
the first
wants to
line of
conceive. Yes, sir.
but she wants to conceive.
To conceive.
Yes,
Now we come to the third. How will you make her to ovulate?
Sir, we will give ovulation induction drugs.
But LH is very high.
So first we have to, sir, we have to suppress LH.
They have to suppress LH.
LH, yes.
So
Give,
how you
sir,
can suppress LH?
2 months before we give GnRH agonist, sir. And then in next cycle we give ovulation induction drugs.
GnRH agonist. How GnRH agonist works? And tell me the name two GnRH agonists basically. Name of two GnRH agonists.
Luprolite, sir.
Luprolite acetate.
Yes, sir.
And
Bozerelin.
Gorserelin.
Gozerelin.
How luprolite acetate comes in what form?
Sir, injectable form.
Injectable form. In what there is no other experts with me. Okay, we'll continue with the luprolite acetate, the injectable form. In what two form it comes? I've given you the what two form it comes and where it is used.
Sir, for long-term protocol, we use this drug. If for ovulation induction for long-term protocol, we use this in previous cycle on the 21st day of the previous cycle.
No. Don't tell about long-term. That I will come later on. Protocols I will come later on. We are on this. Just use what are the types of luprolite acetate.
Sorry, sir.
No, there is one plain type comes, plain luprolite acetate that comes in 4 ml vial, which is used for the ovulation, basically, which is used in the ovulation index. Another is GnRH is a luprolite depot that comes into 3.75 gram of
3.75.
That is used for basically endometriosis. If you want to suppress the ovulation for longer time, in basically all lot of things you can use it where you want to suppress the hypothalamic pituitary axis for a longer time. Yes. Okay, that is used the depot form. If you want to do it for a shorter time, then you use the plain form. Luprolite acetate bulb comes in the 4 milligram vial. Okay, And then other comes in the depot form, that is groceril, that is Joladex, which comes in the market. It comes as 3.6 gram. Okay, this is for your knowledge. It may
Yes,
not be
yes, sir,
asked a lot
definitely.
later in the exam, because now we come to the PCOD. Now we want to ovulate this patient.
Yes, sir.
First, we have to decrease the androgen level.
Yes, sir.
Okay. And first, he wants that her cycle should become regular.
Yes, sir.
Yes, sir.
So how will you do it?
So for regularization of cycles, we'll start micronized progesterone or medroxyprogesterone acetate, 5 milligram twice a day. Every 2 months we have to give, so that there is the unopposed action of estrogen does not take over, and later on she will end up in endometrial carcinoma in her later life. So for that we'll give progesterone every when she is not, for if she is not menstruating for 2 to 3 cycles, then we will give her progesterone, and then she will have regularization of cycles. After that we can start her ovulation induction.
We'll go for withdrawal bleeding, sir.
Yes, sir. Withdrawal.
After withdrawal
So
bleeding,
now,
we can
now
go for...
you again come to the menstrual cycle.
Yes.
Again come back to the menstrual cycle. From the estrogen starts causing proliferation from the 1st to 15th day.
Yes, sir.
Okay. 15th, around 14th, 15th day, there is an ovulation.
Yes.
LS surge and ovulation.
Yes,
And
yes.
then progesterone starts coming in the blood.
Yes,
It is
yes.
secreted by corpus luteum.
Luteum.
Okay. So to regularize the cycle, what you do, you start progesterone from 15 to 25, 5th day, and she will have a withdrawal bleeding at the
End of the cycle.
cycle.
Yes, sir.
So this is one way to regularize the cycle.
Yes, sir.
Okay. You all agreed?
Yes, sir.
Other way, you give OC pills.
OC pills, yes, sir.
OC pills. What OC pills will decrease the androgen level also.
Yes, sir.
And it will take all the function of cut off the hypothalamo-pituitary axis.
Yes, sir.
And it will take all the function of basically estrogen and progesterone by itself. And she will have a regular cycle.
Yes, sir.
Yes, sir.
Okay. Now, ovulate. First, we have to decrease the LH level.
LH level.
LH level by, you have told, by giving OC pills for 2 to 3 cycles. You can give metformin.
Yes, sir.
Metformin will cause insulin sensitizer. It will decrease the hyperinsulinemia, and it will decrease the androgen level, and it may decrease the LH level also.
LH level.
Okay.
Yes, sir.
Then what all drugs is used for ovulation induction drugs?
So we'll start with tablet letrozole, which is most preferred one right now. 2.5 mg would be the starting dose of the letrozole. We can go up till 7.5 mg dose.
From second day of the cycle, second or third day of the cycle.
No. I know letrozole. I know very well letrozole. I want what are the ovulation induction drugs which is available. But first you think what you want. First you think you want unifollicular or
multifollicular.
Huh?
Unifollicular letrozole, multifollicular cyproterone acetate.
Clomiphene
citrate.
No. You should all go and read, because first drug for ovulation induction came is clomiphene citrate. 1960 it came.
Yes, first is clomiphene citrate.
Then tamoxifen was also used.
Yes, sir.
Yes, sir.
Then letrozole came.
Yes,
Okay.
sir.
How clomiphene citrate works basically, how it causes ovulation?
Sir, it blocks the neuronal estrogen receptors. So hypothalamus does not know that there is estrogen. So it secretes it leads to more FSH, which leads to dominant follicle.
It basically it fools the pituitary.
It fools the pituitary, yes, sir.
Makes the FSH to India, and you get a follicle basically.
Yes,
it
sir.
Stimulates the ovary.
Yes, sir.
Then what happens if there is a hypoestrogen? What happens to the endometrium when you use clomiphene?
Sir, endometrium
Thin
becomes
thighs,
thin, sir, atrophic.
Atrophic.
Yes,
That
yes.
was the problem with the
Clomiphene. Yes.
Then came in the market is tamoxifen.
Tamoxifen.
That was
But
also
that
not
did
for a
not-
long time. Why tamoxifen is used?
Breast carcinoma, sir.
Breast carcinoma. Same, another cancer drug, that is letrozole.
Sir.
Okay.
Yes,
Letrozole, how it works basically? Letrozole, what is the mechanism of letrozole basically?
It
Aromatase inhibitor, sir.
directly inhibits estrogen.
It acts on aromatase enzyme and it inhibits that enzyme.
It converts aromatase enzyme inhibitors and basically decreases, tells that there is a less of the estrogen, and then FSH
is
secreted
will
increase
by pituitary. So this is letrozole.
Yes, sir.
Okay, this is the 3 drugs. If patient doesn't ovulate with the 3 drugs, then what you will use?
So then we can use in clomiphene, if it is clomiphene resistant, then we have to find the cause also. Sometimes even if it is weight gain or hyperinsulinemia, then even with clomiphene resistant, we can use metformin. Then they start ovulating. That is a factor. Then if still
No.
it is
Additional drugs, I will tell you later on.
Okay.
That is not that. We are going one by one.
Then
Now 3
gonadotropin.
ovulation induction drugs. Now you have got injectable drugs also, na?
Gonadotropin.
HCG can be used.
Gonadotropin.
Yes.
You should know something about the gonadotrophins. I know as a postgraduate, you should not know too much, but you should know something about gonadotrophins.
Yes.
Gonadotrophins, which are the gonadotrophins basically?
Sir, HMG
is the gonadotropin.
human.
No, I want full form. No HMG.
Human
Everything should be
menopausal
spoken in full form.
Human menopausal
Gonadotrophin. Other?
Sir, FSH, recombinant FSH.
What is different between HMG and recombinant FSH?
So HMG has got 75 grams of both, like LH and FSH, whereas recombinant FSH has just got FSH, purely FSH without any component of LH.
How they are manufactured?
HMG is derived from urine of the menopausal women.
Yes. And FSH? Recombinant, you told, recombinant FSH. Hello?
Yes, sir.
Yes.
So how pure FSH is derived, basic manufactured from the recombinant DNA. Okay, they are all proteins, na?
Yes, sir.
So they are all proteins. That is FSH recombinant is derived from one DNA and that is replicated to a protein. So they are purer forms. Only FSH you can take. You can make LH, that is purer form of LH. In HMG, you take it from the urine of a pregnant, urine of postmenopausal, human menopausal gonadotrophin. HMG, it is named as a. So, which is better?
So, recombinant FSH.
Why?
Because LH is already high, and if we give HMG, the LH will have to.
No. We are talking about the drug. Abhi to hum wahan pahuche nahi. Why HMG is not why recombinants are better than human menopausal gonadotropin? That is basic.
Autoimmune reactions.
Sir, it is
autoimmune reactions, sir. It can cause autoimmune reaction in the since it is human content, and if we give it in
yes,
another
you are
woman,
nearby,
so
you're nearby. So they are the proteins basically which are impurified proteins are present in HMG. So there are 2 types you will find in the market: purified HMG and normal HMG basically. So what happened? The bioavailability of FSH and LH is low with HMG than with the recombinant basically. Recombinant you can predict the bioavailability, but with HMG bioavailability is different for the different people, because how the lady will react with the basically proteins which are impurified proteins which are present in the HMG. Okay, but the cost difference is too much between HMG
and recombinant.
So we have discussed this all armamentarian is with you. Now, how will you ovulate this lady?
So the same way, like because the LH is high, firstly we'll go for the withdrawal bleeding and we'll regularize the cycle. After that, we can go for tablet letrozole 2.5 mg from day 2 of the menstrual cycle, and we can induce that patient. So
And we'll
2.5
monitor the
mg OD for
follicles.
5 days, and so we can monitor. Yes, exactly.
No.
We can monitor the follicle.
What are you planning for? What you are planning? Ovulation induction
Okay.
and timed copulation. You are planning ovulation induction and IUI. 2 things you can do.
Sir, husband semen analysis is normal, so
Normal.
we can try for spontaneous conception,
And
sir.
ovulation induction
Prostate નો
She is
PSA
young,
કરીને
sir,
test આવે છે.
22-year-old.
Okay.
Blood test
Can
કરી
try
છે.
for
You are
એ તમને કરી દે.
જો વચ્ચે 3 દાડા મેં ચેક કરી ને તો ના
You are planning for ovulation induction and timed copulation.
Timed coitus. Yes, sir.
સામાન્ય ડ્રોપિંગ એવું આમ લાઈટ એકદમ એવું ડ્રોપિંગ
Hello?
પહેલા થઈ પછી યુરિન
Yes, sir.
Hello?
પછીનામાં
Yes,
કશું
sir.
Somebody.
સાથે આવે છે એવું નથી
Okay.
Hello.
શરૂઆતનું ડ્રોપિંગ થાય
Yes,
પછી
sir.
So ovulation induction and
Rohan bhai,
time copulation.
sir, excuse me, sir. Rohan bhai,
There is a lot of disturbance.
Yeah,
Munjal,
Sumesh sir,
Kirtan.
2 minutes. Munjal Pandya sir. Rohan
Munjal,
bhai, please mute all other people. Rohan bhai, please do that. Thank you. Okay, sir. You can carry on, sir. Sorry, sir.
Thank you. So you are trying ovulation induction and timed copulation. Okay. Tell me your drug. Hello. Where are my students? They have all gone. I am not able to see the face of anybody. Hello.
Yes, sir.
Manjal, I am not able to see the face of my students.
Rohan bhai, Nikita, hello. Sir, we'll call them. Rohan bhai, show them. Sir, just give me a minute, sir. Nikita phone. I think, sir, the network has gone. They'll rejoin in just a minute, sir.
Better now with cold and cough.
मैम કર્યું મેં કર્યું મેમ મેં કર્યું
Okay, they are visible. Nikita?
Yes.
They have joined, sir. Nikita, are you
They are
audible?
not visible on the screen.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
No, Munjal, am it is written. Let me see whether.
No, sir. I just switched off my video, sir. That is why, sir.
Sir, we can hear you, sir.
We can hear you.
No, you can hear me, but I am not able to see you. Okay, we can continue without seeing each other.
Rohan bhai, if you could check the connection,
Yes, sir.
Rohan bhai, of Nikita Pahwa.
We can see you, sir.
You can see me. Okay.
Yes, sir.
I can see Munjal.
Yes, we can see you, sir.
I can see Munjal, but yeah, Nikita Pahwa. This is.
Yeah.
Yes, sir.
Yes. Now you can see me now. I am visible or not?
Yes,
sir. Yes, sir.
So where were we?
Yes,
We
sir.
were
You are visible,
ovulating,
sir.
ovulating that patient. Okay, you will use letrozole.
Yes,
2.5 milligram
Yes.
OD for 5 days from day 2 to day 5. And then how will you follow the patient? From what day
Yes.
to day 2, what you will do to the patient? Day 2, you will do some investigation for the patient or not?
So serum LH, FSH, baseline LH, FSH, we should know.
That we have done.
And
Na?
baseline serum.
Baseline FSH, LH, estrogen, prolactin. Okay. TSH, thyroid.
D10 follow up करने वाला ना खाली phone.
So day 2 पर also we
So TSH normal.
TSH and prolactin levels you can see, sir.
Day 2, what you have to do, at least you have to do an ultrasound before starting the ovulation induction.
Yes.
Okay.
Okay, there should not be any dominant follicle or predominant
already
something is there. Endometrium is very thick. Then it is not day 2. What day 2 ultrasound you should know. What day 2 ultrasound, what you see the left ovary, right ovary, they should be silent. There should be multiple follicles seen. And endometrium should be less than 5 mm. Then only it is day. Otherwise, you are in mid-cycle, having abnormal bleeding, and there is something, and you are. So when you start the ovulation on the day 2, should be confirmed by ultrasound. Okay. Then you start letrozole. Letrozole 2.5 milligram daily for 5 days. Then 8 days, again you have to do an ultrasound.
Repeat sonography.
Repeat sonography. You have to follow up to find the dominant follicle, whether she is basically there is an effect of letrozole or not. Okay. Then day 10 you will do it. Then you will see whether there is any unifollicular development is there in one follicle is developing or not. Then you will follow this follicle till it becomes 18 mm. 18 mm. Then you will trigger this follicle with HCG. Okay. HCG or LH or anything. There's a lot of things. You can trigger this HCG basically.
Yes, sir.
And then after 46 hours, 48 hours, you will again see the patient, whether follicle has ruptured or not.
For follicular ruptured or not.
Ruptured follicle.
If follicle has ruptured, then you can advise them for the copulation.
Copulation.
Yes, sir.
Yes, you copulate because ovum will be there for 48 hours after rupture.
Yes.
Okay. So in 48 hours, at least they should copulate once or twice in 2 days. And then again on day 2, you know, basically if she has missed her period or not, she is pregnant or not. Since this is a normal, you are thinking, okay, you are thinking normal, everything should be like this, no? But what happens with 2.5? There is no unifollicular development.
So we can go for a step-up dose.
Step-up dose. So
Step-up regime. Yes, sir.
Then what regime will you use? 5 milligram. Double the dose.
5 milligrams.
You can double the dose. Okay. Again, on 8th day, there is no stimulation. There is no follicle.
Yes, sir.
Okay.
Again, 7.5 we can go till.
7.5. But if it is not ovulating with a 5, then you have to use gonadotropins.
Yes, sir.
There is a lot of dose it is given. It is somebody has written 2.5 milligram 3 times, then 2 times, then 1. There's a lot of regimes is going on. But what is written in the book, you should always speak in the exam what is written in the book. Okay. What is written? A lot of regime, a lot of studies has been done in a lot of ovulation, but you should go with the book basically. I am just giving you the concept. Okay.
Yes, sir. Yes, sir.
Then after that, if you letrose, there is a failure of letrose. It is a poor responder. You can say, no? What is difference between poor ovarian reserve and poor responder?
So poor ovarian reserve, the patient will already, while we are giving her ovulation induction drugs, the LH, and we are monitoring FSH and LH levels, her FSH and LH levels will not be altered. They will remain already low on the lower side itself on ovarian failure.
There is simple definition about poor reserve. Means there is a antrum follicle is less. Count is less, then it is poor reserve.
And AMH is less.
If it is not responding to the hormones stimulation, then they are poor responders. Okay, if they are not responders, and one is reserve.
Yes, sir.
So you are clear now?
Yes, sir.
What is reserve?
Yes, sir.
Yes,
Yes.
So now we are going to ovulate her with the HMG. Basically, now we'll use gonadotrophins to ovulate her. Okay.
Good night.
So
Yes,
do you know any resin how to stimulate a PCOD patient for unifollicular development? So here you have to be very careful when you are using gonadotropin. Patient can go into OHS.
Yes,
So
sir.
you have to use very low dose gonadotropin. Even 37.5 you can use, even 75 you can use. You can use combination of letrozole and gonadotropin.
75 milli international.
75
Tropin.
international unit. You can use depending upon the pocket of the patient, how much patient can pay. You can use lot of regimes. Basically, I can use letrozole for 5 days, again gonadotropin for 3 days, or you can use gonadotropin for another 5 to 7 days, as it is basically. So now we have ovulated her. She has got unifollicular development, but with the timed copulation for 3 times, 4 times you have done, and she has not conceived. Then what advice you will advise? You are getting good follicle, she is not able to conceive. Then next.
IUI, sir.
Then next
Intra fertilization, sir.
In vitro fertilization, sir.
What?
So intrauterine.
What?
Intrauterine insemination.
The IUI is, what is IUI?
That is
IUI
intrauterine
insemination of sperm.
Yes, sir.
Yes, sir.
Yes, sir. So how IUI is done basically?
So first, it can be done in a spontaneous cycle also or induced cycle also. So first, if we are already ovulating the patient, so we can do an induced cycle. First, we ovulate the patient, then we give HCG trigger, and then after that, after 36 hours of HCG trigger, within 36 hours, we do IUI. Sir.
36. IUI is done after 48 hours. IVF, for IVF, it is 36 hours. For
36
oocyte
hours,
retrieval,
yes,
it is 36 hours. For oocyte rupture, it is 48 hours. Okay.
Okay, sir.
Yes, sir.
So how IUI is done basically? So that ovulation induction is done, unifollicular development of the oocyte. Basically follicle, then rupture of the follicle, and then preparation of the sperm. Okay, that is more important. They will prepare the sperm, wash the sperm, give you the 0.5 ml of wash sperm. That is to be installed intrauterine. That is intrauterine insemination. Sperm preparation is totally different discussion by itself. So next time, if I'll get time or something, so we will discuss about it. So now we have ovulated the patient, this, that, then everything is faked. LH level is not going down at all. You have tried all these things. You know about myoinositol?
Yes, sir. Yes, sir.
And myoinositol
Yes,
preparation.
vitamin B8. Vitamin B8, sir. It is.
What is this? Myoinositol, chironositol are drug preparation, or this is a what? How it acts?
Vitamin B8, sir. They are forms of vitamin B8.
So how much we have to give, and till what dose we have to give, till after, for what we have to give? There is something written as a myoinositol and chironositol. You have heard about, huh?
Yes. Yes.
So basically, they improve the environment of the body, which they tell ki it decreases the androgen level, prepares the ovary for good folliculogenesis. So you get good oocytes for it. So that is the only they say. So it is not a drug. It is basically supplements, myoinositol and chironositol.
So
that has to be told last when it is asked by the examiner. It should not be in the ovulation induction. So first is metformin, OC pills, metformin. Then you have got ovulation induction drug I have discussed and everything. Now if LH level is not going down, then we have
So we can go for ovarian drilling, sir.
Yes.
In that case. So the stromal drilling would decrease, the stroma area would be decreased, and in that case, LH level would be low. If in case anything is not working.
Yes. So we have to do ovarian drilling. That is a surgical management of PCOD when there is a very not responding to the medical therapy.
PCOD, yes, sir.
PCOD. Okay. So ovarian drilling से पहले क्या करते थे? What is written in the book?
Yes, sir.
Till Levantine syndrome.
Wedge resection.
Wedge resection.
Wedge resection of the
It is written in the book, na? Wedge resection. Then
ovary.
Ovary. Wedge resection of the ovary. When there was no laparoscope. Then there was evaluation. Then laparoscope came in. Then with the laparoscope power came. The electrical power came in the hand of the surgeons. Then they started burning the ovary. Okay. So first they were cutting the ovary. Now they are burning the ovary. What is the basically how much power you have to use for PCOD?
The rule of 4.
4 what?
The rule of 4 we use, which 4 punctures which are of 4 mm depth on each ovary for 4 seconds and using 40 watt of energy, sir.
Energy, that's good. So we have done the surgical management also. After doing surgical management, how many months we have to wait that everything will show her LH level will go down?
3 to 6 months.
And she will start ovulating.
So
by
for
herself.
3 to 6 months, then we have to repeat the. Sir, we have to repeat the AMH and LH levels after. Sorry, sir.
Yes, you're right. 3 to 6 months. Some patient will respond to 3 to 6 months, and then what is AMH? AMH, you have written AMH is 7.
It's an anti-Mullerian hormone. Anti-Mullerian hormone, sir.
Yes. What it basically says,
Yes, sir.
What it clarifies, basically,
Now,
what gives you the AMH is high means what?
So it's a measure of ovarian reserve.
Reserve. What reserve?
It's a measure of ovarian reserve, sir.
What reserve? Basically, which follicle? There are 2
2
types
to
of
9
follicles.
mm. They secrete small. Yes, sir. Small antral follicles, sir. Small antral follicles.
No.
So granulosa cells of antral follicles would be producing this hormone.
So they give there are primordial follicle and antrum follicle. Hello? Hello? Hello?
Sir, I think again their connection lost, sir.
Yeah.
Just okay, they have joined, I think. Nikita? Nikita, hello.
Thank you, sir. Yes, sir. Yes,
Okay,
sir.
Yeah.
Yes. So we have got in ovary primordial follicle and antrum follicle.
Antral follicle.
So they give the reserve about the primordial follicle, they say.
Okay, sir. Yes.
So you know how the basically ovulation takes place unifollicle from primordial follicle to antrum follicle to dominant follicle.
Graphian follicle.
To Graphian
follicle, and then after ovulation.
Corpus.
Ovulation. So
Yes.
what is the total time taken for this whole journey to become oocyte to ovulate?
It's not fixed. Follicular phase is not fixed.
fixed.
It depends. Luteal phase.
But from primordial to antrum follicle, it is fixed.
Yes, sir. It is.
So at least it's like 3 months. Okay, near about 3 to 4.
Okay.
Yes. from primordial follicle. Primordial follicle is under paracrine control. Antrum follicle is under endocrine control. So you can't tell primordial follicle to become an antral follicle. No drugs can make primordial follicle to become antrum follicle.
Antrum,
Only the
yes.
body of the patients basically can make the primordial follicle to become an antrum follicle. Then antrum follicle it becomes in our hand. Then we can basically stimulate. Then we can stimulate. So we see the antrum follicle of the patient. That's we count the antrum follicle. Okay.
Yes, sir.
Understood?
Yes,
So
yes,
now
sir.
we have ovulated. So now it is, if time finishes, then we can stop.
Yes,
Also.
sir,
Okay.
sir, yes, yes. We are just overshooting the time now.
Yeah,
And,
yeah. So so we can,
Thank you, sir.
anytime you can tell, I can stop, because this lecture can go for this
Yes,
small
sir.
patient can be managed for in, it will take
Yes,
in
sir.
one. So we will now cut
Yes,
short
and
everything.
especially the expert with like you, sir. With an expert like you, we can have different kinds of management, sir. Students will be benefited, but yes, sir, we have to conclude now.
Yes.
So, sir, I thank all three of the faculties for this wonderful session and the wonderful insights for the students. And sir, can we just have 2 or 3 sentences by each faculties as a concluding remarks? Blessings to students, sir, for their exams.
I think only Sumesh sir is there. The other two might have
Nobody
lost the
is there.
connection.
So for exam, you should read only from the books. Listen from everywhere, read from the books, and Munjal, what your teacher says, that only you should say. Okay.
No, but you,
I have told you. I have
Yes,
told you
sir.
a lot of things. That is for your basically knowledge. But exam is different game by different game. What your teacher says, that is only correct. That is only right. And what your book says, that is only okay. So
yes, sir.
So we have managed halfway. Another next time.
Sure, sir. Yes.
I will try to arrange another
Thank you.
session.
Thank you, sir.
Another session with you, sir.
Okay. Thank you.
Thank you,
Best
sir.
of luck. Oh.
Thank you, sir. Thank you, sir.
Chalo. Munjal. Hello.
Yes, sir. Yes, sir.
Did you enjoy?
Absolutely, sir. I was listening to the whole session, sir, actually. And you said it right, sir. There are times, even sometimes teachers may be wrong, but that can be only judged when they have read the books. Or else it was like, it would be like, might is right. And you kept on saying that particular thing only. And that is amazing thing. Because reading is required to make, the judgment. And you kept on saying the same thing, sir. So thank you so much, sir, for conveying it crystal clear, actually.
Thank you, Munjal. Thank you, everybody. Good night. See you.
Sir. Thank you.
Bye.
Thank you, sir.
Thank you, sir. So we conclude this 4th session of PG Symposium, and the next dates will be declared very soon with cases. Thank you.
Thank you, Kirtan. Thank you, Akshay, sir. Thank you, all the students, and thank you, all the experts, for their wonderful inputs. And this particular session will be there on YouTube as well after 2 or 3 days, so that you can refer it to and would know after a few months, after reading it properly, that where mistakes were committed. Thank you so much, sir. Sumesh, sir, it was a wonderful session. Thank you so much, sir. Thank you, Kirtan.
Okay, thank you. Good night, everyone.
And thank you, our web partner, Orange Rose, Rohan Bhai and Jalak man. Thank you so much. Good night.
Thank you, sir. Thank you, sir. Thank you, sir.